Good evening to everyone and welcome to today's session. COMED K 2015. Generally, COMED K is a acid test as to know how well is your preparation for the immediately forthcoming state MD entrance, whether it is Tamil Nadu PG or AP PG. All these exams are there on March 1st. So this time COMED K paper around 35 to 40 questions are unreachable, especially radiology and radiotherapy are the tough cracks. But still I was looking, where is Liddell, where is Barter, where is Gittelman? It is there. I was looking, where is the apoptosis? It is there. And most of our favorite questions we discuss in our mock tests. They are all available. We welcome Shaz, Kalyani, Kiran, Krishna, Vijayawada, Shruti, Chandu, Praveen, everybody who are online, to know what is COMED K 2015 this time. Coronal atresia. How many of you have actually taken COMED K? Out of you, only one. Okay. I hope a lot of online students also might have taken COMED K. Coronal atresia, typically the bony atresia is more common compared to that of the membranous atresia. So this is how in the posterior part of the nasal nares there is an occlusion in the form of coronal atresia, as what you can see. Bony is more common than that of the membranous, is what you need to remember. And unilateral is more common than bilateral atresia in a ratio of about 3:2. Laryngomalacia. It is an expected topic, high yield topic. Omega shaped epiglottis, collapse of the supraglottic structures, eriepiglottic folds, prolapsing into the airway, they are all true. How about interarytenoid clefts? The interarytenoid clefts typically become deeper. They are not narrow in case of the laryngomalacia, is what you need to remember. See, this is epiglottis, doctor, in the mouth. This is called glossoepiglottic fold. This is epiglottis, and this is the base of the tongue, and you have the epiglottic fold, vocal cords, etc., etc. Suppose if the laryngomalacia patient expires on expiration, how the glottis looks like versus that of at the time of inspiration. So this is that omega shaped epiglottis in the case of the laryngomalacia is what you have to fundamentally remember. Fibrous dysplasia. Classically it is a hematomatous growth. Actually 3 options are all correct. I thought examiner like our mock test forgotten about except. You took the COMED K, doctor? You felt the same? Right, very good. It typically presents in first and second decades of life. You have got a ground glass appearance, is what you have to basically remember. It is the maxilla among the craniofacial bones most commonly affected, not the mandible. So there is a reason D become except. Maybe examiner should put except and make answer as D. So this is a classical plain film. This is called as ground glass appearance, which examiner is expecting from you in case of fibrous dysplasia. And that woven hematomatous bone of fibrous dysplasia classically histopathologically looks like this, is what you need to understand. And one more important question that can come for the APPG, TGPG, TNPG is in fibrous dysplasia you have what is called Chinese character or alphabet soup appearance, it is called. Histopathologically is what you need to remember. One gunfight will definitely be there in every PG medical entrance. Generally cruciform shape, where do you find was the recent Jipmer or whatever the entrance which we have discussed in a series. Where do you see rat hole appearance? See doctor, this is the typical appearance of the entry wound depending upon the different scenarios. If it is a contact wound will be either circular or cruciform. Then similarly, if it is a short range one, as you can see in the option C, it is a rat hole appearance. So I leave to the literature, contact versus close versus short versus medium distant. In case of the firearm injury, what are the differences in the literature? Otherwise, in newsformedico.com we will upload tonight this explanatory answers and host this discussion video in youtube.com/onlinembbs. Strychnine, how does it act? Tetanospasmin, strychnine, one botulinum toxin, cholera toxin, one toxin based question ke bina, there is no entrance exam. So strychnine acts by inhibiting the glycine. Declaration of Tokyo, this was a repeated MCQ. Typically they have decided that there are some rules of torturing. Whether you do it in a entrance exam coaching or any victim who is available for you. Choking, where do you see? This also another very repeatedly asked MCQ. Shotgun. A young girl, arthralgias, hypertension, discrepancies in the pulse, it's called pulseless disease. One question on vasculitis, without that there is no entrance exam. So it is Takayasu arthritis. A 50-year-old has fever since 5 days with hypotension, with desaturation, with interstitial opacities. See doctor, what is the definition of SIRS? Systemic inflammatory response syndrome. What is the definition of ARDS? What is the definition of ALI? Acute lung injury. All those definitions, clinical definitions, you need to be 100% sure doctor. I am very happy to see 46 plus online viewers. So ARDS. Broad-Bend sign in constrictive pericarditis. Definitely one question will come on cardiac tamponade versus constrictive pericarditis versus restrictive cardiomyopathy. Where do you find square root sign, etc., etc. Kusumal sign, pulsus paradoxus, everything you should review. What is Broad-Bend sign? Constrictive pericarditis classically leads to a pericardial knock. That all of us know. Then in the 11th and 12th ribs in constrictive pericarditis, they become indrawn and there is a narrowing of the intercostal space because of that pulling effect caused by that constricted pericardium at the time of inspiration. It leads to intercostal narrowing, which is classically called the Broad-Bend sign, is what need to be remembered. Tails index and TUPSI are used where? This is too much. This is MD level question nahi hai. DM level ka hai. If you did this 11th question wrong, no problem. Earth and sky will not meet. But if you have done Broad-Bend sign wrong or laryngomalacia question wrong, you are losing to your competition. Simple concept. So doctor, it is in the case of the carpulmonale. What is TUPSI? Tricuspid annular plane systolic excursion. Can you give me the board? See, basically in carpulmonale what is happening? The right ventricle is opening up into the pulmonary artery, and any pulmonary hypertension is leading to the right ventricular failure. And what is draining into right ventricle? The right atrium. Between the two you are having the tricuspid valve. In a scenario of a right ventricular failure, what happens to end systolic volume? At the end of the systole of the right ventricle, the volume remains in the right ventricle only, because it is unable to pump it into the pulmonary artery. So the right ventricle transverse diameter alters, and that in turn will affect the excursion of the tricuspid valve at the time of the ventricular diastole. So that is the reason tricuspid annular at the time of systole, tricuspid annular systolic excursion, tricuspid annular systolic velocity and myocardial performance index, they are all the ones to judge the right ventricular dysfunction in a case of the right ventricular failure because of pulmonary hypertension, which is called cord pulmonale, is what you need to basically remember. In Doppler echo, रंगोली खेलते वक्त अगर ग्रीन कलर दिखाए तो उसका मतलब क्या होता है? Very, very fundamental question, right? So, typically in the color Doppler flow, forward and backward and turbulent, three types of scenarios will exist. So, doctor, red or orange indicates flow is towards the transducer, and if there is any blue color, that means flow is away, and if at all there is a green color, that means there is a turbulence in the flow. That is what you need to basically remember. Nephronophthisis, is it among our high yield topic list? It is there, but very far away. It is some bottom of the list, least yielding, but 20-30% of questions will be from least yielding topics, another 10-20 are from the rarest points out of the commonest topics, but around 65 to 70% are definitely from the most expected high yield topics. So typically nephronophthisis, even if you know juvenile nephronophthisis, how it is inherited, blah blah blah, you will not know, I can bet it. What are the associations of nephronophthisis? I dialed one of my nephrology friend and asked, tell me what are all associations of nephronophthisis? What? What ophthisis is what he has asked. So, purely academic question. Huh? So, doctor, if you did this question wrong, don't worry. Your tears don't deserve that. Don't waste your tears. So, retinitis pigmentosa, Leber's congenital amaurosis, then amblyopia, they are all associated with juvenile nephronophthisis. Then cerebellar ataxia, portal fibrosis, situs inversus, they are all the other important associations of nephronophthisis. I can bet it. It is most uncrackable question. Now doctor, thyroiditis is a high yield topic. If you don't know that subacute thyroiditis, subacute lymphocytic thyroiditis is also called silent thyroiditis, you are out of the game. If you thought that Hashimoto is called, Graves is called, something is called, no, subacute lymphocytic thyroiditis is called painless thyroiditis, otherwise called silent thyroiditis. And in this, what do you see, doctor? Both hyperthyroid, every time there is a destruction of the follicles, thyroid follicles, there is a release of the thyroxine, and hyperthyroid state will be there, and also the moment thyroid gland is exhausted, hypothyroid phase will also be there. So that is the reason, doctor, it is a brief period of thyroidoxicosis will be there. Then examiner's temptation to drag you, because ESR is high, glucocorticoids, there are the other forms of thyroiditis, not here. So how do you treat it? But how do you diagnose it? The best way to diagnose a silent painless thyroiditis, which is subacute lymphocytic, is by doing radioiodine scan. During hyperthyroid phase, iodine uptake is suppressed. Hypothyroid phase, iodine uptake is increased. Whereas if you take Graves' disease, there is a diffuse increased uptake in a hyperthyroid individual. Radioactive iodine uptake in Graves kaise hota? Graves presents like hyperthyroidism and there is a diffuse increased uptake. But if subacute thyroiditis is presenting in a hyperthyroid phase, there is a suppressed iodine uptake. Why suppressed iodine uptake? Basically, why hyperthyroidism occur? Because of the release of the follicles which are already containing the thyroxine. That's what you need to remember. So how do you treat it? Not steroids. We give beta blockers is what you need to basically remember. Pragna is asking a question. Sir, what about D? What is in D? Let us see. No. In the earlier question, I think, yeah, ESR. ESR is like a very non-specific finding. I'll check on the ESR, what percentage of people it is normal, etc. But C is a very confidently told truth. What is cardiomyopathy? So cardiomyopathy, yeah, basically there is a transient phase of cardiomyopathy which is called stress-induced cardiomyopathy. Stress-induced cardiomyopathy. Have you heard any of your patients telling a story? I still remember one of our patients telling a story. There was a 82-year-old man. He himself was driving at around 1 a.m. in the morning and brought his wife. She is in a collapsed state. The ward boys are in a completely sleepy state, REM sleep, nobody is ready to carry. I still remember he and me holding that lady and bringing into the emergency ward. Intubated, gave a DC shock, she got up. So she had a cardiac arrest with absolute respiratory arrest. So once she survived, he was telling, oh doctor, she is my only reason that I was thinking of living in, because he married her when he was just 19 and she was 12. And now he is 84. That was way back 15 years back. So he was telling, then I said, if she would have died, you would have lived very happily another 20 years. All these days you are imprisoned by the marital love. So no doctor, it was not like that. His father, while reading newspaper, died. He was a school teacher. Within 24 hours, his mother died. So in our family, very loving couples, doctor, he was telling. So that's the reason, I'll tell you doctor, happiest times are when you are on at work. Otherwise, life is more boring. When you are MD General Medicine, you have got lot of stories to listen. Right? So, some people suddenly after listening a bad news, they will die, no? CM YSR died. Another 10 people died. Listening the news. How will that death occur? They are not shot to death. So, whenever there are few people in whom high catecholamine levels will be there. You say be careful. If you belong to cardiomyopathy group, suddenly if your friends say you got first rank in PG medical entrance, means you will get a cardiac arrest. So, there is it is also called transient apical ballooning syndrome. It is transient, but it is not very high. So, what is the difference between this and other situations? In any situation, whenever there is any cardiac failure, your tendency is to give a inotrope to rise BP. But in cardiomyopathy, you should not do that, because they already have got a high catecholamine state. That is the fundamental difference between the regular cardiomyopathy and this is what need to be remembered. Then what is the treatment recommendation in these people? You will give intra-aortic balloon pump fluids and you will give negative inotropes. You should have guts to do that. In somebody who has got a cardiac dysfunction, to give a negative inotrope like beta blocker or calcium channel blocker is considered to be the treatment of, this is also called broken heart syndrome, is the other name given for the Takotsubo cardiomyopathy, is what you have to basically remember. You don't need to give any anticoagulation. Why it was called Takotsubo? Originally in Japan, oyster catching nets are called Takotsubo. There is some relation between the two. So, and octopus traps, not oyster, octopus traps. So this is a typical picture of that apical ballooning whenever you do cardiac angiography. And similarly you can also see it is called transient apical ballooning. Before the normalization, when echo was done, you can see the apex of the heart of the right ventricle completely ballooned up, is what you need to remember. Now doctor, Kernon sign, very good. Pragya is asking another very good doubt. Sir, then why are we giving nitrates? Why are we giving nitrates? Nitrates have nothing to do with worsening inotropic state. They have nothing to do with worsening of the, why we are giving beta blockers is to, they have a high catecholamine output. To counter that we are giving beta blockers. That's the point. And another thing is, high catecholamine statement, there is an intense veno and vasoconstriction. Nitrates being a dilator can also help the heart. Kernon-Waltman sign, where do you see? Oh, this is a very easy question. Kernon's notch, we see in case of transtentorial herniation, right? In uncal herniation. What is Kernon's sign, doctor? Typically, whenever there is any midline shift because of the mass effect, the contralateral cerebral crus become indented. See, I have a bleed on the right brain of me. That right brain bleed led to raised intracranial tension and compressed on my left side cerebral crus. Ultimately, the fibers corticospinal descending tract which is passing through my cerebral crus will go down and decussate and once more come to right side from my left side which got compressed. So ultimately what will happen? My paralysis which occur will be occurring on the same side as my bleed, which is causing raised ascity. But why it is called false localizing sign? Whenever you have a right-sided paralysis, you will expect a bleed to be there on left side. So that is the story of Kernon. What is a dense disease? This is little, I think a nephrologist is on the board of COMED. Too many questions on nephrology, honestly speaking. So what is this basically? It's a X-linked nephrolithiasis, X-linked recessive state of nephrolithiasis. There is a proximal tubular dysfunction in these people. Hence, it leads to Fanconi and it shows proteinuria, which is a low molecular weight proteinuria. That is the story of dense disease. Fanconi syndrome, tubular proteinuria, hypercalciuria, calcium nephrolithiasis, nephrocalcinosis and ultimately leading to CRF is called as the dense disease, and it is CLCN5 gene abnormality which is being identified is what you have to basically remember. Now doctor, secondary hyperparathyroidism in chronic kidney disease, when will it occur? Whenever the GFR level is below 60 ml per minute. In a negative marks exam, don't chase the devil. So, when will you do fibrinolysis in pulmonary embolism? Another devil chasing question. 14 days was the answer given. But it is, the protocols, clinical protocols differ. There is in acute state versus chronic state. etc., etc. So I don't know what reference examiner had gone with 14 days. I'll recheck that. Then in acute MI, what will you do? You will give everything but not amlodipine. Amlodipine is a calcium channel blocker and it's a negatively inotropic agent. Already MI is depressing heart. Further you want to give a myocardial depressant? Too much. Will not give. I think easy question. Anybody will answer. Which is not invasive diarrhea. If you know that toxigenic diarrheas are non-invasive and dysentery causing situations are all invasive, Campylobacter jejuni becomes the answer. AD PKD, actual answer was given was C. It is not fatal in early middle age. It starts in early middle age. The first cardiothoracic surgeon of Andhra Pradesh was our patient who had AD PKD. A very nice person. I still remember up to 68 he lived with that, and he entered renal failure at the age of 68, and by about 70 he passed away. It was synonymous with more or less a normal existence except last 2-3 years of renal failure. I still remember listening a very good account about VSD, ASD and cyanotic heart disease, how to differentiate. He came to the clinic and on a routine review and said, Doctor, a lot of you postgraduates will not be taught exactly on cyanotic heart disease. He took a paper and explained. I still can never forget Dr. Raghav sir, who is a very good cardiothoracic surgeon. AD PKD. So the median age of death generally is around 60.5 years. I think that answer examiner may change is what I am hoping for. But the other options may, you have this triad. You have all the triad of features, triad of loin pain will be there, mass will be there, attacks of renal coli will be there. Renal nephrolithiasis is common in those people. So D should be ideal answer. That's a point. That's right. Hematuria will be there. Hematuria will also be there. So that's the thing. Then Parkland formula. Examiner is bored in asking how much you will give. So he want to know what you want to give. It is an isotonic formula you will be giving. What is diffluence lesion, doctor? It is gastric arteriovenous malformation. Right? Then it can lead to bleeding sometimes. Or it can be found on endoscopy as a lesion. Calot's triangle, what are the boundaries? You have the cystic duct, common hepatic duct and cystic artery. So they constitute cystic duct, common hepatic duct and cystic artery, they form the boundaries. Inferior surface of the liver is forming. Now I think cystic artery was given. Okay. This was the original answer given by COMED board. The same, they gave C as answer, right? So I think A should be the answer. Correct. Agreed. Then which is not true about congenital diaphragmatic hernia? Diaphragmatic hernia. So basically, if you look at the hernia of the foramen of Morgagni, anterior is Morgagni, posterior is Bogdelac. Lot of times it is an incidental finding in adult. Incidental finding in adult where it is discovered. So that is the reason they are more common in the age group of 40, 35, 30, like that, rather than newborn. Unlike the Lakh, which is symptomatic at a much earlier stage. When was Human Genome Project completed? You don't remember which year you finished housemanship. If at this rate questions are asked and you don't get seat, one time you have to go and recheck which year you got finished housemanship. So doctor, it was 2003. Huh? Then this is the most disgusting question. Additions are most common, we all studied. Percentages, who will study, doctor? Just it is only testing your patience and tolerance. Can you withstand the tolerance or not? So it is 12%, not 15% is obstructive hernia. Inflammatory is 15% but not 8%. I actually did not check. I am believing the founder of the question must be knowing the foundation of answer. Huh? Then what is, but don't worry, this kind of questions, even if they are asked in the state PG entrance, be happy. Nobody is going to answer. Anybody who answered loses 1/4 of the limb. So that way, no worries. Persistent vitelline duct remnant is one question. Meckel's diverticulum के ऊपर कुछ ना कुछ होना चाहिए ना? हाँ. So the general rule, doctor, if the high yielding topic is among the options, no other will be the answer. If two high yielding topics are there among the options, since they are high yielding anyway, you know how to eliminate. But that is rare situation. This is the biscuitest question in COMED K. Which breast disorder occurs during breastfeeding? Acute mastitis. Don't go and argue with judge. Is it acute breastfeeding or chronic breastfeeding? That is not what examiner is trying to check you. Acute mastitis.